All right, so then we get into hip dislocation. So again, here, most commonly is posterior, so it's going to move up like that, so they're going to internally rotate and abduct, or adduct, I'm sorry, yeah. So adduction, internal rotation. Basically, it's some kind of impact to the long axis of the femur. So chances are they're going to need some type of surgery. You know, they may have some atrophy of the muscle. Again, if you saw something like this, it would be, you know, post-op. And then here's the other type of dislocation. So it's moved anterior inferior. So in this case, they're going to be externally rotated and abducted. Okay. And then that's the mechanism of injury, is forcing the hip into that position. And that's pretty much the same as the other kind of dislocation. All right, so you have slipped capital femoral epiphysis. And this is, again, if you see a situation where you have an adolescent with hip pain, and maybe they have a limp or even without pain, and they don't describe any specific type of an injury, then you almost want to suspect something like this until you rule it out. Okay. So it may be that there's some kind of an abnormality of what happens is that the growth plate, it's slipping at the growth plate. So this is a substantial situation that needs to be dealt with. So this is the type of thing where you can refer it out. So if they're having hip pain in an adolescent with an absence of trauma, you almost want to suspect this until you can rule it out. So there's going to be pain deep in the hip, pain with all the ranges of motion. It's chronic pain, and it may have become more painful. And that's basically what you're going to see is just limited range of motion, and they may not even be pain on palpation. And then amalgam coccygenesis is just another way of saying osteoarthritis of the hip or DJD of the hip. And then again, basically it's affecting the cartilage. You have chronic stress on the hip. Just wear and tear of the joint, right? So pathology basically is this progressive degeneration of the articular surfaces. A lot of times it can be one side or it can affect both sides. I mean, you hear about a lot of people getting hip replacements. You know, even Eddie Van Halen had a hip replacement. So they can have overuse activities, deep hip pain in the hip. And again, it's just like any other DJD. When are they going to complain of the problems?
In the morning.
Yeah. Either when they first start to get moving or when they stop moving. So anytime when they transition from movement to non-movement. So it's going to be in the morning or then maybe at night, changes in barometric pressure, pain on weight bearing too. And then again, X-ray is going to be the definitive thing to identify. And so then here you can see the top of the joint. Here's the femur. This is the acetabulum. Right there, there's no space. Usually there should be a gap in there between where the cartilage. So what it's done is it's completely worn down, and there's extra calcium building up. So a lot of times what they'll do eventually is do a hip replacement. Okay, so now we get into the last thing of the inert tissue, which is the bursitis. And then basically with any kind of bursitis, either you can have an acute blow or you can have repetitive irritation to that area. And then the bursa is going to swell up with fluid. And then it can be, if it's more red and feels hot to the touch, it can be inflamed. And then the greater trochanteric bursitis obviously is going to be at the greater trochanter. And then again, you can find that with Ober's test, although Ober's test is more for the TFL, but they could have pain when you're doing that because of greater trochanter bursitis. And then psoas bursitis is going to be more deep to the anterior part of the hip, and that's going to be with more chronic repetitive flexion. You're not necessarily going to get that from direct blows. So it's going to be deep pain in the hip, maybe popping with hip flexion or extension. So extending the hip is going to put pull tension on the psoas muscle and might irritate the bursa. So you could have pain on flexion or extension. And then some of these hip tests, Patrick Faber's or Thomas tests, would show some symptoms possibly. All right, so then we come into contractile tissues. So you're either going to have groin pulls or hamstring pulls. So what types of things do you do to assess contractile tissue? So you would see, if it's a groin pull, you would do resisted adduction. Hamstrings, you do resisted hip or knee flexion. Hip extension and knee flexion. Okay, now we get into the vascular condition. And this is avascular necrosis of the hip. It's also called leg calf-Perth disease. It can be a continuum of maybe a degenerative process to the hip or some type of vascular problem. Sometimes the etiology is unknown. People just develop this problem. It could be if they've had prior trauma to the hip that affected that artery that goes to the head of the femur. But basically, what does avascular necrosis mean? Yeah, avascular meaning the blood flow, and then what's necrosis mean? Death. So yeah, you have the bone tissues dying because of lack of blood. So is that a serious problem? Yeah. Usually they're going to do a hip replacement. They can happen over long periods of time. So you can see there's instead of this being more of a completely normally rounded bone, it's kind of changed its shape, and you start getting irregularities at the border of it there. So it can occur progressively over a long period of time, and then eventually you can get just to be bad enough where you just need a hip replacement. So it could be it could appear within normal limit, or they may have a limp. It's probably not going to be tenderness to palpation, and the range of motion is going to be limited. As far as the definitive evaluation is going to be X-ray or MRI. And that's it.